feeling like jumping into the deep end of the pool.
I have one quick question.
Yes.
For the metabolic acidosis, you said that the calcium levels are high.
One more time.
Did you say that the metabolic acidosis for calcium is high, or is it low?
I don't know if I said anything about that. So hold on. Let me look at my.
High. Okay. It says low though, so that's why I was confused.
So let's check. Metabolic acidosis. Potassium is high. Did I say calcium? I shouldn't have said calcium. It's
Okay.
potassium
Okay.
is high. Sorry. Yep. Potassium is high. No calcium. Has nothing to do with calcium. Thank you for that. Everybody fix their potassium. Okay. Because of DKA. So, when we're talking about shock and multi-organ dysfunction syndrome, first and foremost, shock. We need to know what it means about the definition of shock in order to know what we're moving on from. The failure of the cardiac system to maintain tissue perfusion of vital organs. So it's the failure of the cardiac system to maintain tissue perfusion of the vital organs. That is by definition what shock in general means. There's different stages of shock, which we're going to go over today, and there's different types of shock that we're going to get our feet wet in. Progressive shock is one that we're going to talk about after we talk about the classifications of shock. So, when we're talking about the classifications of shock, we have one is our hypervolemia. So that means they have low volume. What do? We give them volume. Cardiogenic shock has to do with the failure of the pump. Usually cardiogenic shock is the number one thing that happens with myocardial infarctions or heart attacks. Inadequate, an impairment or failure of the myocardium. Septic all has to do with infection, overwhelming infection. Neurogenic has to do with the spine and brain. Anaphylactic is that vasodilation of those vasoactive substances that causes that particular shock. So it's usually induced by an allergen or something that causes them to vasodilate. So now, talking about the stages of shock, we have first and foremost compensatory, which I know I say funny, but you know it's there. So this is where the patient starts to compensate for their shock. I think that's all self-explanatory. Confusion may occur, respiratory becomes a problem, increases due to the acidosis. Then the compensation for that acidosis would be then happening. And then the body shunts blood. This is very important to remember about compensation, is the body is shunting blood from these places to the brain and to the heart. So they're eliminating a lot of other organs. This is why in compensatory or compensation stage of shock, the patient's skin becomes cool and clammy on the extremities because they're shunting blood to the heart and to the brain. Because the body thinks, ooh, those are the vital organs that need it. But they forget that so does the kidneys. You know anything about kidneys, you're going to hear this again later on. Kidneys love blood, they don't like blood under pressure. And they don't like not enough blood. Now we're running into a situation where they're not having enough blood. Okay, so that becomes a problem for them that we'll get to. Progressive shock is hypoperfusion. Hypoperfusion. That's a problem to the tissue. Tissues need to be perfused. Again, we would see it in the compensation, that cool and clammy skin. But now we throw into the mix hypoxia. Shallow and rapid respirations. Continues. Then it could be the potentially going into DIC. Disseminated intravascular coagulation. This is microclotting in all vessels that have blood. Could be capillaries, not necessarily always veins. Could be the tiniest of the little vessels. The venules, they have microclotting and they can burst. So that becomes a bigger problem. Then progressive, holy cow, leads into irreversible. Once it becomes irreversible stage of shock, just what it says, it's irreversible. We want to catch it before it gets to that point. You'll see what happens. Liver and kidney functions fail, the blood pressure lowers, the acidosis get worse, and then that becomes the multi-organ system failure. Keep in mind, with any shock patient, no matter what stage they're in, shock is an ongoing systemic assessment. It's our one-on-one because these stages can happen fairly quickly. So it's one-on-one assessment of that patient. Ongoing is the key. So, what that said is once we identify the different types of shock, then it all determines on the treatment of how we're going to help and try to fix before it turns to irreversible. So fluid replacement becomes one thing, crystalloids or colloids, either 0.9 normal saline or lactated ringers. The only time really we see lactated ringers is usually in surgery and in the ICU. By the time they're on lactated ringers, it's a problem because they're sick. Sick. Complications of all this fluid is, of course, cardiovascular overload. Pulmonary edema. Keep in mind with pulmonary edema, we need to assess their crackles. There could be a change in mental status. We should already be monitoring the urinary output. And then, of course, monitoring vital signs before it gets to this point. Then, what can happen with complications is the third thing, which is called an ACS. A stands for abdominal. C stands for compartment. So abdominal compartment, the S stands for syndrome. So abdominal compartment syndrome. What ends up happening is the fluid leaks into the abdominal cavity. What ends up happening is surgical decompression is needed ASAP to relieve that abdominal cavity of all that fluid. So what ends up happening is that fluid dumps literally into the abdominal area cavity. So fluid leaks into that cavity and surgical decompression is needed ASAP, if not soon. Okay? So we're going to go over our complications again. 1, cardiovascular overload. 2, pulmonary edema. Monitoring vital signs of urinary output, mental status, then of course lung sounds with crackles. And then the ACS. Monitoring the blood pressure is definitely one in this whole scenario of what we need to monitor. Low blood pressure is yikes, because as we saw, the blood pressure lowers enough to get into irreversible, and there's no coming back for that patient after irreversible. So the vasoactive medications that we can give, or should already have instilled it or put it or started it, we know that we need a central line for these medications. Really don't like perfuel unless we don't have anything else. So the first one would be what? There's 2 that you can say, so there's only 2 answers really. So raising of blood pressure, vasoactive medication, what'd you like to give? Who? Low pressure is a beta blocker, will lower the blood pressure more. Epi is only for heart rate.
Dopamine.
Dopamine is 1. Remember about that extravasation. What's the other one if dopamine fails? Norepinephrine. be an old saying. I'm gonna tell you guys it, so it helps me hopefully remember. It's kind of sad though, but when dopamine failed, we used norepinephrine. Nowadays, they jump right to norepinephrine now, but it used to be a saying called, the trade name is Levophed. It's Levophed, leave them dead. Because by that time, they were very sick, and they usually didn't come back from it. But now, they might not last long on dopamine, and then they start on the norepinephrine. So, 2 vasoactive meds that could be used to raise that blood pressure. Remember, it's titrated to the desired blood pressure. What is that desired blood pressure we said systolic should be? 90. 90 systolic. So they're going to titrate, or we're going to titrate, however way you want to look at it, for that systolic blood pressure of at least 90. Is that a medication that we can just turn off once we get that systolic of 90? No. It's going to be sustained for a while, for whatever long that is, depending on the patient. Then we will start weaning them off slowly. It's not one we can stop abruptly. Again, monitoring for the extravasation. Okay? Infiltrates, we don't want it to infiltrate, because that will lead to that necrotic. If it does, what is the medication we can give intradermal around the site to bring it back to life, that skin? Rigidine. Heard those words in farm. I know you did because I told you, for the majority of you guys. So Rigidine, intradermal injections around the extravasation for that patient to get that necrotic tissue. Hopefully before it gets necrotic, we give that and it brings it to life, back to life. Kind of like that song, Back to Life. You guys know that song? I'm dating myself, I'm sure. Okay, so some of you may know. So, moving on to more of specifics. Hypovolemic shock. I really like this illustration of what it means to give you guys a big picture. So I'm going to talk about it. Decreased blood volume, because that's what hypovolemia is. It's a loss of blood volume, which then decreases the venous return. We know that blood has to come back to the heart, go back into the vena cava to start that whole circulation process again for preload, right? Everybody remembers that word preload? Decreases the stroke volume, decreases the cardiac output. What's normal cardiac output we mentioned earlier?
5 to 6 liters.
Per minute. Yep. 5 to 6 liters, per minute. Then, what if I don't have a monitor? How am I going to know? How much the urine output should be then? 30 mLs per hour. Then it leads to decreased tissue perfusion. Remember, you're going to be sick of hearing the words perfusion. But with all of this is based on not enough volume, long and short of the story. So what we can do then, now here, with this decreased urinary output, what happens is increased heart rate compensation. They will become tachycardic, high tachycardic, because they're trying to compensate, because they're going to take what volume they have and pump it faster, thinking that's going to help in the world of our hypovolemic shock. So 0.9 normal saline for treatment. Blood, you can always give blood. So let's talk about administering blood really quickly, because that's one of the things we are supposed to be able to do. So tell me some of the things that we need to know about infusing or transfusing blood.
You have to be in there for the first 15 minutes from the start.
From the start, first 15 minutes, you'll see a reaction, okay? Take what vital signs? I didn't hear that part. You need baseline vital signs before starting that in that first 15 minutes. So like 30 minutes before. What kind of vital signs would you like to take?
Blood pressure, temperature, heart rate.
So blood pressure, temperature, heart rate. Those 3 things are essential. Why is that essential?
Because if they have a reaction, then their temperature could go higher, or it could, and their blood pressure could go low, or could go high. It just depends on how they react to it.
Yep. And why is that 15 minutes so important? What would you see in those vital signs besides what she said? What is an indication that there's a reaction within those first 15 minutes? That's way too late. Oh my goodness. That's dead.
I meant more like change in mental state.
So you're going to see a change in the vital signs, what she mentioned. 1 degree of a change in temperature within those, from that pre-baseline to that 15 minutes, if you see a degree change by 1 degree, that patient's having a reaction to that blood or blood product. okay? That is why 15 minutes are so important, because you have to do it from the start and monitor those 15 minutes, because that patient starts having difficulty breathing or any of that, that one temperature change is gonna be a difference. So, what is the only IV fluid that could be hung with that transfusion of any blood or blood product? 0.9 normal saline. So in the case of, oh my gosh, the patient become more tachycardic, have that 1 degree change in temperature in that 15 minutes, what should we do with that blood and blood product? Stop it, and what do we do with that 0.9? Wide open. Flush. And then do we just leave the tubing with the blood and blood product in there and say, okay, have a good day? What do we do with it?
We discard it.
We discard it to who?
The blood.
We take it back to the blood bank. We discontinue, we send it to blood bank, we notify the physician. Okay? And let them know what happened. He might order Benadryl or Lasix or whatever the case may be that needs to be done. And then of course we have to document the whole thing. Whole thing. We can also, with the hypovolemic shock, put him in what position in the bed to help that venous return? Trendelenburg, yep. Bring it back to the core, all that fluid. Bring it back to the core. Antidiuretic Holmorn does play a role in this scenario. One thing to make note of. And two, again, decreased urinary output will let us know something more is going on. If we see, again, decrease in urine, and then of course anywhere else that we have practice fluid, missing fluid, third spacing, all of that kind of stuff. Because third spacing would be hypovolemic shock as well. Another illustration I really like. So, cardiogenic shock, we said it's something wrong with myocardium, the function, the pump, however way you want to look at it, usually from an MI. So there's a decrease in the cardiac contractility, so again, the pump. Decreases stroke volume and decreases urinary output. Then you have three things that happen. Pulmonary congestion, decreased tissue perfusion, systemic decreased perfusion, decreased coronary perfusion. So all of this happens, but then it goes back up to decreased contractility. So something is preventing perfusion to that heart muscle. Again, a blockage in the coronary artery, hence the MI, right? So the goal then is, of course, give them the medical treatment they need, like percutaneous coronary intervention, which is a fancy way to say get them to cath lab, to open up that vessel to allow blood flow. Keep in mind, no blood flow to the heart equals MI, that equals dysrhythmias. Those dysrhythmias we mentioned already. VTAC, VFib, dead. So no blood flow to the heart, decrease, that equals an MI, that equals dysrhythmias. What medication, also known as an opiate or narcotic, can dilate blood vessels in cardiogenic shock? Morphine is the winner. We know the acronym as MONEL, right? But not in that particular order. But morphine needs to get on board to dilate the blood vessels in cardiogenic shock. So not only would we oxygenate, possibly give nitro, etc., but there's also other pharmacological measures we can take too. So we mentioned the nitro. Dobutamine. Dobutamine helps with the contractility. Then we know nitro dilates the coronary arteries. The dopamine can help with that blood pressure if it becomes an issue. Antiarrhythmics like amiodarone, old school lidocaine that they're still using, it pops its head up every once in a while. And then other vasoactive drugs would necessarily be things we mentioned. We may have to help with the blood pressure. Not only we may not use the dopamine, but we can use norepinephrine as well. So that's some of the treatments with that. So when we're talking about then multiple organ dysfunction syndrome, which really should go at the end of the conversations, but when 2 or more organs fail, that is considered multiple organ dysfunction or MODS. When MODS happens, that is also known as irreversible shock stage, right? Because once 2 or more fail, the patient organ function is decreased. If you think about what we talked about before with the blood shunting to the brain and to the heart, it's also getting that cool, clammy skin in the extremities. We mentioned the skin, the kidneys, the GI, and all that is missing out. So what you will see is a decrease in urinary output, right? Because that is a sign that the kidneys are not working as a whole. So these patients, pardon me, are severely ill, and of course irreversible explains that. Circulatory shock, the septic, the neurogenic, and the anaphylactic shock all falls into this category. So as a whole, with the circulatory shock, there's a precipitating event that happens. So if it's neurogenic, somebody dives into a shallow into the pool, gets a brain injury or a spinal cord injury or an accident or something. If it's a precipitating event for anaphylactic, they got exposed to a bee or to peanuts or something that's going to cause an allergy. And then the septic shock is infection. That is that precipitating event. Then it leads to vasodilation. Then from vasodilation goes the inflammatory response. So we're thinking of swelling, right? Edema, swelling, throat closing, big lips, big tongue, however way you like to look at that. There's a maldistribution of the blood volume. So that goes along with that third spacing. It's going into a different spot, causing that edema. Decrease in venous return, decreased coronary output, and then guess what? A decrease in tissue confusion. And that is what we're trying to avoid. So with all types of shock in general, our goal is to treat the types of shock and to bring them back to tissue perfusion is our goal. So again, with the use of fluid replacement, again, blood components may be needed for the hypovolemia. Watching out for those complications of that overload, okay? Pulmonary edema. Vasoactive medications, one thing to keep in mind is we titrate up for those vasoactive medications to get the desired output we want with the dobutamine specifically, or to get that systolic above 90 in our other vasoactives. And then we would wean them once it's been sustained for a period of time. With these vasoactive medications, we're monitoring blood pressure. If the patient has already had an arterial line, then it's going to be precise blood pressure monitoring. By the time they're in stages of shock, they probably will already have that in place because of precise blood pressure monitoring. It says every 15 minutes per your book, but probably want to do it more frequently. Nutritional therapy. One thing I like to point out is administration of an H2 blocker or a protein pump inhibitor. Everybody needs some kind of acid reducer because once the patient's blood is shunted away from that GI, the acid is going to have a field day. When we talk about ventilators next in respiratory chapters, one thing that we'll talk about is gastric decompression. So they have an NG tube to decompress because they need to allow for room for those lungs to expand and the diaphragm to go up and down with inhale and exhale. But we want to put an acid reducer on board also because of the stress. So people under stress decreases that acid production. So we give them that to calm that sense. Maintaining comfort in a cardiogenic shock. 3 things to remember about that is assess and understand the shock with cardiogenic, really all of them. 2, identify any changes. That is why shock is an ongoing frequent assessment, right? And then understanding the underlying cause and why that patient is doing what they are. So, in the stages of shock, when you're that primary nurse taking care of that patient one-on-one, you need to have a friend on that unit with you that can communicate with the family and explain to the family and the loved ones of what is going on with the patient. You, as a primary nurse, will not have time to do that. Why? Because shock is a frequent, ongoing assessment. Okay? So you find a friend to educate. Then, we also need a friend to talk about end-of-life issues or end-of-life procedures or what they would like done because Once they reach that irreversible stage of shock, then that needs to discuss end of life with the family, okay? And again, you are gonna be with that patient, you need to find a friend that can help and assist with that. Kristen, was that hand up or are you just holding your pen? Yeah. No, okay, I just wanted to make sure it wasn't, you had a question. So keep in mind, again, making sure the family is taken care of just as well as the patient. So going along with all that support. Another quick point about MODS, 75% mortality rate, promoting communication, and then of course controlling all of this treatment, maintaining, providing. Now, in shock, the last thing we're going to worry about is feeding the patient, first off, right? In the stages of shock, it's usually 24 hours after, then we think nutritional. But initially, with the whole event happening, nutritional is not something that we're worried about first off. Usually 24 hours after. If we can get them past that irreversible and we bring them back to compensating before they progress, then we can feed them. So once they're out of danger per se.
So then would you hold off that proton pump inhibitor for 24 hours after? Or
No,
would you add
you
it
would
in
give
with
it.
your,
You would do that initially to reduce the stress. Yep, reduce the stress. Any questions about any of this? Yeah, Melissa.
When you're in shock, is this a quick death or is this something that like?
That can linger, depending on, yes. Depending on what was a precipitating event that happened to cause the shock, and then patient's comorbidities prior to.
So that would be maybe hospice at the end of life. Okay.
Yeah, if they, depending on what stage of shock and what caused it, it could very well be quicker than hospice.
Okay.
I mean, it could happen in the ICU and you don't even move them out anywhere. You know what I mean?
Yeah.
It just depends on the patient and the shock and the precipitating event. Any other questions? Okay, so next week, first test,